Welcome everybody. I'm going to be talking to you guys about the chronic obstructive pulmonary disease, most commonly referred to as COPD. So make yourself comfortable, grab yourself a cup of tea, find yourself a nice spot, and we'll go ahead and talk about COPD. We'll talk about the definitions. We're going to do an overview of the physiology of the respiratory system. We're going to look at the pathophysiology of COPD and the comorbidity with other medical conditions. And we're also going to look at common treatment approaches to COPD and also how medical family therapists can be part of the treatment team in helping patients with COPD. As we move forward, I want to give you a little bit of guidance as how we move on. Each slide has a separate audio recording. So what you do is you click on the slide that you're ready to review, and then you can click play and be able to listen to the audio associated with that particular slide. So each slide has a separate audio recording, and you can go as quickly or as slowly as you want through those. So let's move on. Okay, let's talk about what COPD is. It's an inflammatory disease, and it's largely associated with exposure to tobacco smoke. Now, with many patients, they will have been smokers themselves, and they will obviously be at risk of COPD. But you'll also need to be looking at family members and people that are close to smokers themselves, as people who are exposed to secondary smoke or even third-hand smoke can be at risk of developing COPD throughout the years. So COPD describes a group of connected symptoms according to RAVE 2007, and that includes what's called shortness of breath or dyspnea. It includes chronic cough. In fact, many people with COPD have what they call smoker's cough. It includes excessive mucus production, or more technically referred to as sputum production. It's associated with restricted airflow and also chronic inflammation of the airways. So all of those symptoms collectively describe chronic obstructive pulmonary disease itself. Now we're going to move forward to the next slide and talk about the physiology of the respiratory system. Okay, let's take a look at the physiology of the respiratory system. And as you see up on your screen, you can see how the human respiratory system is structured. The function of the human respiratory system is to actually supply oxygen throughout the body and also expel carbon dioxide. This is called the ventilation process. And we'll start with the top. If you look at the nasal vestibule, which are the nostrils. And so what the nostrils do is serve as a gateway to receive oxygen into the body, and the nostrils serve the function of warming the air and moistening the air. They also serve to filter particles and organisms before they move further into the body. Of course, oxygen can also be taken in through the oral cavity, but you don't have the same functions as you do through the nasal cavity. Now once they go through those two cavities, it'll go through the throat or the pharynx, and then from the pharynx down into the trachea and windpipe. So you'll see further down below the throat, you'll see the term trachea, and we also commonly call that the windpipe. And it's a cartilage type tube that actually has lining in it with hair-like features called cilia. And so the lining of the windpipe actually serves to filter out contagions and particles just like the nostrils did. But it also serves one other function. The cilia actually has a rhythmic motion that helps to expel particles that are inside of it, so it pushes it up out of the windpipe into the throat. So it helps to serve to pull particles out, plus it also helps bring out mucus. This is called expectorated. Now as the oxygen goes in further past the windpipe, it goes down into the two main bronchi. So you'll see it split left and right. And the bronchi also has the similar lining to the trachea of the cilia, so it serves the same function in that it helps to filter and expectorate particles and organisms itself. And then from the main bronchi, it goes into the bronchioles. And so it breaks up into smaller different gateways as it goes further into the lungs. And then from the bronchioles, it goes to tiny sacs called alveolar sacs. And so from there, it goes into pulmonary veins and capillaries, and then helps provide oxygen into the bloodstream while also extrapolating carbon dioxide to be expelled through the lungs. You'll also see that the lungs are sponge-like, and I'm going to give you a little bit of a heads up on the next slide. There will be no audio to it, and there'll be a picture of some pig's lungs, and when they show those lungs, you can actually show the expansion of the lungs by putting oxygen into it, and you'll see the lungs grow up and go down. Now in this particular still picture you won't be able to see that, but this is a picture of a demonstration of it. So if you do have a little bit of a weak stomach, you might go ahead and just skip over that slide. Okay, let's look at the pathophysiology of COPD. According to Stephen and Yu in 2008, they describe COPD as a chronic airway irritation with excessive mucus production and also pulmonary scarring. And so you'll see we have this is a chronic condition that occurs over time. It's inflammation that causes the mucus glands to enlarge and increase its mucus secretion, according to Falvo 2009. And so the lining of the air passages become irritated over the chronic issues. They become swollen and clogged with mucus blocking airflow in and out of the alveoli. Now the alveolar walls ultimately become destroyed, leading to permanent enlargement of the air spaces, which is commonly referred to as emphysema. And this ultimately leads to the functioning area of the lungs to decrease. So you lose functioning throughout the lungs as this condition progresses. As we'll actually talk a little bit more about some of the treatment options to try to make the most use of the lungs that are functioning left. And so the result is inadequate gas exchange, which, as we talked about earlier, is called ventilation. And so you don't get yourself enough oxygen, and you also don't expel enough carbon dioxide. And so when you aren't able to bring enough oxygen, that leads to mental and cognitive difficulties due to oxygen deprivation. And as you build up more carbon dioxide, that actually can lead to what we may see as apathy and excessive drowsiness within the patients. And we'll talk more about some medical family therapy interventions that can help reduce the risk of hypoxia and hypercapnia as we move forward. So you'll see it's a chronic condition that actually is a cycle as it moves forward. So as the irritation happens, it leads to more mucus production, which then actually creates more difficulty in expelling the mucus, and then you lose the ability to for the ventilation to occur throughout the lung and the respiratory system. Now when patients have COPD, many times it's later stages in life, and so many times there's complications related to other conditions as well. Now looking at COPD itself, you'll actually find that COPD has a strong impact on other systems of the body, particularly the cardiovascular system. And we'll talk more about the specific impacts of COPD on the heart and other processes later on. But I just want to share that there's a lot of comorbid complications related to patients with COPD. They are more at risk of developing lung cancer. It's also associated with osteoporosis and also metabolic syndromes. So it's a very complicated scenario whenever somebody presents with COPD, because sometimes they will impact and be impacted by other conditions that they're presenting with. So let's go into a little more depth related to the comorbidity issues related to COPD. As somebody develops and has progressive COPD, they can actually suffer from a condition known as polycythemia, and that is increased red blood cells within the system, which actually ultimately makes the blood thicker, increasing viscosity, and then that makes it a little bit more difficult for the blood to flow throughout the body. And one treatment option that may be required is phlebotomy, and that may be required periodically, and that includes removal of the blood to help improve the viscosity of the blood flow. Another common comorbid condition is actually the cor pulmonale, and that is a failure of the right ventricle of the heart. So as the blood becomes more difficult to pump throughout the body, it creates a strain on the heart, and we'll talk about how the heart becomes hyperutilized. And so the right ventricle of the heart must pump actually against what seems to be resistance within the body, and so the heart becomes enlarged as a result of it. And associated with that enlargement of the right ventricle is you may be experiencing edema or swelling of different parts of the body. So the general circulation backs up and blood returns to the right side of the heart. Now, as a patient suffers from edema, that could actually lead to other symptoms, particularly when the edema is associated with the digestive tract. So they may be experiencing nausea and vomiting, or it could be skin ulcerations. So as you can see here, there's several comorbid complications associated with progressive COPD. Let's talk about the prevalence of COPD. According to Armstrong, COPD affects more than 10 million adults in the U.S., which also includes more than 5% of all U.S. adults. It's actually the third leading cause of death among adults in the U.S., and that accounts for more than 120,000 deaths annually, according to Stevens and Yu. The annual healthcare cost associated with COPD is $37.2 billion, according to Stevens and Yu 2008. Now, one interesting change that we've seen with the statistics are the differences in gender within deaths associated with COPD. In 1959, men dying of COPD outnumbered women 5-1. However, in 2003, women accounted for 51% of all COPD-related deaths, according to Pulmonary, Croxton, and Weinman in Kiley, 2007. Let's talk about the progression of COPD. COPD is largely irreversible and incurable, which means it is progressive and degenerative. And so treatment goals really do include relieving the patient of the symptoms that they're experiencing, trying to help improve their functioning, whether it be occupational or quality of life, also helping to limit any complications related to the symptoms, according to Sutherland and Cherniak, 2004. And actually, COPD can be classified according to its level of severity between stage 0 through 4, based upon airflow measured by spirometry and also the presentation of symptoms in a medical setting, according to Garcia and Jenkinson, 2007. So we're going to look at the classification of COPD throughout those stages next. You can see this classification system for COPD, and this is actually according to the gold, and it sounds ironic, it's actually the gold standard, but actually the gold suggestions for how to treat and diagnose COPD. So what you'll see is in stage 0, this related to a patient that could be at risk of developing further symptoms. And so in this stage, patients present with a chronic cough and mucus production, but lung function measure is normal, so there's really no current functional impairment at this stage. Now, as the disease progresses, it may move on to the mild stage, stage 1, and this includes the chronic cough and excessive mucus production, and airflow is mildly limited at this stage, And many times patients may still be unaware of the declining lung function, although they may be aware of some of the symptoms and how they're impacting just their daily activities. And as the disease progresses, it can move on to a more moderate stage, or what they call stage 2. And so this is when you experience that shortness of breath during exertion. Also, you'll find abnormalities found in spirometry. And so as you measure lung capacity through spirometry, you'll see some abnormalities related to that. And then on stage 3, which is a severe category related to COPD, you'll have increased shortness of breath, and you'll have significant changes in spirometry. And quality of life is impacted at the severe level here. And then in the final stage 4, which is very severe, quality of life and activity are severely affected by the symptoms associated with COPD. And it can also have potentially life-threatening consequences associated with it as well. Okay, let's talk about the psychosocial, spiritual aspects that are commonly associated with COPD. So according to Dudley, Glasser, Jorgensen, and Logan in 1980, and also according to Falvo in 2009, you'll see many common issues such as social isolation, withdrawal from family, limited and restricted activities, anxiety. In fact, there's a 36% prevalence of anxiety among folks with COPD. You'll find depression, and similarly, you'll find a 40% prevalence rate of comorbidity between depression and COPD as well. You'll see fatigue, emotions such as anger. You'll find sexual difficulties, which can also lead to interpersonal challenges within intimate relationships. You'll find embarrassment, grief, and neuropsychological deficits that could result from chronic oxygen deprivation. So let's dig into these a little bit further and talk in more detail about the psychosocial spiritual aspects. Much of the literature talks about a very common cycle associated with anxiety and shortness of breath. And so we'll focus on Falvo's explanation of it here. And so many times when people experience that dyspnea or shortness of breath, they actually may have a fear of dying at that moment. So fear of death either immediately or fear of death in the long run as the disease progresses. And so as many people start to think about that and experience that level of fear, that actually raises their level of anxiety. And anxiety has an impact on the physiology of our respiratory system. And so a lot of times with people with experiencing this anxiety, what they'll do is they'll avoid activities that they associate with that shortness of breaths. And so there becomes a very unhealthy cycle of avoiding activity, which then leads to deterioration physically, which then also exacerbates the condition even worse. And so in their efforts to try to avoid making the condition worse, they inadvertently make the disease progression worse itself. And so anxiety will actually raise the respiratory rate. And so as somebody feels anxious, their heart rate will increase, their need for oxygen consumption will increase, and so their respiratory rate will correspond with that. And so it creates a very vicious cycle for a lot of patients there. And so one of the outcomes that you'll find is a very restricted lifestyle among patients with COPD. So they tend to avoid a lot of things that they may have done previously for enjoyment. They may avoid a lot of social activities, and we'll talk about some of the other conditions or issues that may impact their social relationships as well. So the avoidant behavior tends to become more predominant, and then as you avoid one behavior, sometimes the anxiety isn't resolved, and then you'll avoid another behavior, and then avoidance becomes expansive until you're very limited on what you're able to do or willing to do. In addition to the anxiety, anger and depression are very common related to COPD. I mentioned earlier about the 40% comorbidity between depression and COPD, but as people start to lose their functioning and start to see the progression of the disease, many times grief emotions, emotions related to adjustment are very common experiences for them. You also see many times sexual difficulties arise out of people with COPD. And so a lot of times people that have shortness of breath may see sexual activity as something that can trigger that dyspnea, and so they'll avoid sexual activity because it actually leads to symptoms that they don't want to experience. And so what they could do is actually impact intimate relationships within families. And so it not only impacts the patient, but ultimately impacts the romantic or intimate relationship that they have with their partners. Let's continue talking about psychosocial spiritual aspects of COPD. And as I mentioned in the previous slide, grief and loss are common experiences related to it, because as the disease progresses, if you recall, it's not something that's curable. You pretty much learn to manage it over time. And so a lot of times they may lose independence that they had previously. They may lose the ability to work in the same capacity that they had before. They actually may lose self-esteem, as their activities associated with self-esteem may be altered as well. And as we know, behavioral activation is a very important component to mental health. And so as you start to reduce your behaviors and your activities, many times that can lead to experiences of loss and grief as well. Another common experience with people with COPD is embarrassment. Sometimes at the later stages, as severity increases, the use of oxygen tanks may be required. And so many patients can use oxygen tanks only when they're home, or maybe at night, or maybe during the daytime. But a lot of times it becomes a little more challenging to find out where you can go, what's allowable, if you're carrying an oxygen tank with you as you travel around. And so many people may find themselves kind of self-conscious about having to find environments that are safe to bring oxygen tanks into, or just by the fact of bringing it with them. And so there's a lot of embarrassment associated with that. Also, there's the embarrassment of having difficulty breathing. Sometimes the activities that are associated with just getting out and about and living life sometimes can lead to that shortness of breath. And so having people observe you during that experience of experiencing dyspnea actually may be an embarrassing experience for them, and may lead to them avoiding those situations so they don't feel embarrassed. And then also another embarrassment too could be the chronic cough that's associated with COPD. As I mentioned before, there's the cougher's cough, which can be associated with it, and that could be embarrassing in some scenarios as well. Plus, as you have that excessive mucus production and you expectorate that mucus, it can be foul smelling too, and that can be another source of embarrassment for many patients. And then also another important psychosocial aspect here is the neuropsychological difficulties that could be associated with COPD. And as I mentioned earlier about hypoxia, hypercapnia, as you don't get enough oxygen into your body, that actually can impact the patient's judgment, problem solving, ability to think. And so they actually have many psychological symptoms that could be associated with that inability to get enough oxygen into the body. And also very similar to that, as you try to ventilate gases in and out, sometimes you can't get the carbon dioxide expelled from the body. And actually, if you have excessive amounts of carbon dioxide, it can lead to just apathy and excessive drowsiness. And as we talk about interventions later on, we'll look at some breathing techniques that can improve the capacity to bring in oxygen into the body and also expel air or carbon dioxide that needs to be pushed out of the lungs as well. So we'll talk about that here in a little bit. But before that, let's talk about some culture and diversity issues associated with COPD. Okay, let's talk about the culture and diversity issues associated with COPD. And as I began to research more about COPD and understand that largely it's associated with exposure to smoke or other environmental toxins, I began to look at what culture issues or diversity issues may be more prevalent within the populations experiencing COPD. And so, as I mentioned earlier, COPD is largely associated with tobacco use. And as I work here in the Chickasaw Nation, I'm very aware of the challenges related to the tobacco use and health associated with the population that we work with here. And so, statistically, American Indians use tobacco is 30% higher than the general population. In addition to the higher usage, American Indians many times begin smoking earlier than other groups, and that's according to Forrester, Rhodes, Parr, Baker, Davey in 2000, also Levin, Welch, Bell, and Casper in 2002, and Momper, Reed, and Dennis 2010. So it's a pretty, the literature does support that as a consensus too. Now I want to also point out too, within the Native American populations, many times tobacco is sacred, and so many times either people that are being treated by traditional healers or traditional healers themselves using tobacco may be exposed to tobacco smoke during spiritual ceremonies and traditional medicinal practices, according to Momper, Reed, and Dennis. I also went to grand rounds at the Chickasaw Nation Medical Center and got to meet a lady who is over their public health in the Navajo Nation. And she shared with us some very common ailments that she's seen within the traditional healers in their environment. And so many times tobacco and whiskey are used in healing ceremonies in the Navajo tribe. And so what they're finding are that the healers, as they are themselves exposed to the use of those chemicals, they actually themselves are more at risk of developing health-related complications from that exposure. Now there's some interesting pushes throughout Native American communities about the appropriate use of tobacco. And so there's use of commercial tobacco, and as you may know, commercial tobacco sometimes goes through a different process before it's actually presented to the public for consumption. And so if you are able to grow or manufacture your own tobacco, many times that you're able to have more control over what chemicals or the purity of the actual tobacco itself. And so there's some many interesting values within the use of that in spiritual settings, as far as using non-commercial based tobacco within spiritual ceremonies. But overall, we'll find that the American Indian population is at a very high risk of COPD because of some of these statistics and the exposure to the tobacco that we see here. And there are many biomedical treatment options to COPD, and I think the most prominent one is using medicine to help treat it, so drug treatments. And so we'll talk about some of those drug treatments now. Inhalers such as long-acting and short-acting bronchodilators are very common prescriptions for people with COPD. And so the bronchodilators help to reduce the hyperinflation and also help with the shortness of breath. In fact, there's some that are called rescue inhalers and some that are prevention inhalers. And so the rescue inhalers are ones that you use as you start to feel the symptoms come on, and they have an immediate impact with the inflammation process. And so systemic corticosteroids can be used as an anti-inflammatory to help open up the airways and allow people to ventilate better. Some of those inhaled therapies include what they call dry powder inhalers, nebulizers, pressured metered dose inhalers, and soft mist inhalers. And so as prescribers look at which one to use, many times they actually will decide to use other devices to maximize the use of some of these inhalers. And so if you've ever seen anybody use an inhaler, sometimes they're taught how to inhale it, but there's sometimes a gap between the inhaler and the oral cavity, which allows some of the medicine not to actually be inhaled the way it intends to be inhaled. And so sometimes they'll have these devices to help connect the oral cavity to the actual inhaler itself to make sure it all gets into the lungs. So there can be some extensions for the inhalers that can help improve the use of medicines there. Some other drug treatments that want to be considered are some antibiotics for bacterial lung infections. Now if you remember back to the physiology, much of the function of the windpipe, the trachea, the bronchioles is to expel mucus and to actually block or expel organisms or substances that come into the body. Well, people that have inflammation within those, sometimes the cilia aren't able to expel the things that come into the lungs as easily as maybe with a healthy patient. And so they're much more at risk of developing pneumonia and respiratory infections than the general population. So many times antibiotics have to be used quickly to prevent some of those infections from becoming very difficult to treat. And also people with COPD are recommended to have annual vaccinations to help prevent flu and pneumonia. So the FALVO 2009 says to us that we need to be very cautious if we have patients with COPD and helping to make sure they don't skip regular vaccinations for that. Some other treatment options for COPD include behavioral interventions and pulmonary rehabilitation. And here is where we can find some other treatment team members that can help to treat use some other treatment methods for COPD. And let's start with education. So treatment team members can help educate patients and their families about COPD, about risk factors, about the progression of the disease, about precautions that can be taken to help prevent progression of the disease, and what ways we can use to, what behavior changes can help minimize some of the symptoms and associated with it. So education and psychoeducation is an important function within interventions here. Another one is exercise conditioning. Now, as mentioned before, many times restricted activity becomes a common scenario with people with COPD, whereas the opposite needs to occur. And so helping patients become more active, helping them exercise better, helps their bodies to become more efficient in using oxygen. It helps them become stronger. It helps the functioning to become better. And so using exercise conditioning is an important intervention with people with COPD. Another one is energy conservation. And so there are some ways that people can learn to change their daily routines just to maximize their energy use. In fact, as we talk about breathing techniques later on, there's actually breathing methods that can help maximize energy conservation as well, and we'll talk about that more later. Physiotherapy is another common approach to helping people with COPD. And so as we'll talk about chest physiotherapy later on, that could be implemented by a physical therapist or a respiratory therapist. And so there's lots of ways that PT, RT, OT can also help out. And then ultimately vocational counseling. So many times people may lose the ability to perform at the level they had before or in the environments that they had before. And so vocational counseling can help them accommodate their environment or their job to their particular limitations or disabilities. And so all of those are interventions that could be helpful for people with COPD. Let's talk about some other additional behavioral interventions. According to FALVO 2009, you can use certain breathing techniques that can help people with COPD. Some of the specific ones include pursed lip breathing, which helps slow breathing rate and helps remove some of that trapped air from the lungs. So as I mentioned earlier in the previous slides, one of the goals of the respiratory system is to bring in adequate oxygen and expel the excess carbon dioxide. So this pursed lip breathing helps to bring in more oxygen, and it helps remove trapped air that remain in the lungs as well. There's another type of breathing exercise called diaphragmatic breathing, or commonly known as deep breathing techniques. And as I mentioned in the previous slide, this is used to help conserve energy. It also helps create more space in the lungs so that you can actually bring in more oxygen as you breathe. And also daily exercise or walking is very common to be prescribed to patients with COPD to help build strength and endurance for them as well. Now, FALVO 2009 gives us some additional behavioral interventions and pulmonary rehabilitation activities. One is chest physiotherapy, and that helps remove the drainage in the lungs. And so as people with COPD have a difficult time expelling or expectorating that excessive mucus that's being produced within the lungs and the respiratory system, one thing that they'll do is they'll lay down and they'll have somebody do what's called clapping on their chest. It almost seems like they're beating on their chest to help break up some of the mucus that's collected within the lungs. and it helps remove some of that drainage that's in there. And so after somebody has chest physiotherapy, sometimes it breaks up that drainage, and then they're able to kind of cough it out or expel it out in various ways. And so that helps people that experience COPD as well. Also, avoidance of certain irritants that kind of make it worse, such as smoking and environmental pollutants. Now, as mentioned before, much of the COPD that you may encounter are related to exposure to smoking. And so many times you may encounter family issues. Maybe the entire family may be smoking. And so secondary smoke exposure may be an important issue to consider here. And so as you work with the patients and maybe quitting smoking themselves, or working with patients and the family members, so that way the patient isn't exposed to smoking in their home environment or other environments. Also interesting, I found this interesting, sometimes dietary changes can help relieve some symptoms related to COPD. And so consuming smaller meals actually reduces pressure in the space required internally. And so it actually helps to create more space for the lungs to be utilized. So as you eat less, lungs can use more space, and it helps people experiencing shortness of breath and other restrictions related to COPD. Also avoiding foods which could cause gas or bloating, which can also create more pressure internally on the lungs too. And then a very, very important one too is encouraging patients to increase their fluid intake. And as they increase their appropriate fluids, such as water, it helps to clear some of the respiratory secretions as well. And so we're talking about fluids that will be helping with this respiratory secretions, not necessarily fluids that will be counteractive within it. So we want to make sure we're encouraging patients to drink the proper fluids there. And there are some other treatment options for people with COPD. Using resistive breathing devices can also be used to help exercise muscles and increase breathing capacity. And that's from Falvo 2009. An additional thing from Falvo is using supplemental oxygen to increase blood oxygen levels, which can help with shortness of breath, increase endurance, and completing daily activities. As I mentioned earlier, they could have portable oxygen tanks that they may take with them as they go about their day, or they may only need oxygen at certain times of the day. There are also, interestingly enough, there's surgical interventions for COPD, and such as lung transplants. So if somebody's progressed to the point where their current lung capacity and functioning is so impaired that that they know that they could be at risk of death, they could be a candidate for lung transplant. And another one is lung volume reduction, and that's removing non-functioning areas of the lung to help increase lung capacity. So as the disease progresses, what happens is the walls of the alveoli start to deteriorate and they become non-functioning. So parts of the lung that remain in the chest cavity are actually parts that don't work sometimes. And so with this surgical intervention, they'll go in and they'll remove the parts of the lung that no longer work and are functioning, and that helps create more space for the functioning parts of the lung to be able to function. And so that's one option for treating COPD. And then also there's very strong evidence from one article from Suzuki et al. In 2012 that acupuncture has a strong impact on improving shortness of breath symptoms. And that's been shown in that article to work with people with COPD and asthma. And so acupuncture is something to be considered as well as a treatment option for people with shortness of breath symptoms. Now there are many types of providers that will encounter patients with COPD. You'll find primary care providers, internal medicine, family practice. Many other mid-levels will encounter patients with COPD just in their general practice. You'll also find that geriatricians will encounter people with COPD just because of the population they're focused with. And then also if you have patients that suffer from moderate to severe COPD, may be referred to a pulmonologist for evaluation and treatment. And a pulmonologist is a physician who specializes in treating lung conditions, according to Favreau 2009. Okay, let's talk about some roles that medical family therapists can serve in helping patients with COPD. And of course, we know that collaborative care is a very good approach to people with chronic health conditions. And so, according to McDaniel, Doherty, and Hepworth in 2014, in their book Medical Family Therapy Integrated Care, second edition, they talk about behavioral health consultations to try to help improve health-related behaviors and adherence to treatment. And so medical family therapists can help track the patient's medical and mental health outcomes when you meet with the patient and review the EHR related to patient care. And so you can also track medication and treatment adherence to find out if they're following through with what prescribers have asked, and also if they're using the medication in appropriate ways. And I'll make sure that they're taking it as prescribed, following through with the methods that can help improve daily usage of the medicines. Also help support patient relationship with the PCP or the pulmonologist in treating the COPD. And so helping to coach the patients on maybe how best to interact with a provider if they may have a limited amount of time. Also may help the patients understand and navigate our system a little bit better, and maybe we can also help serve as an advocate at many times to help with patient agency too. Also, psychoeducation about the diagnosis of COPD. So just like we're talking about COPD in this presentation, you could also be asked to help provide a brief introduction to some of the psychosocial and spiritual aspects of COPD, and also be able to discuss and process treatment options with the patients. And of course, we're going to encourage follow through with behaviors that can help improve their health related to these conditions. And so behavioral activation, such as exercise, following through with what the physicians or prescribers may be asking them to follow through with, and then very importantly, self-management of the condition. As we've discussed up to this point, COPD is not a curable disease, so it's a disease of management, self-management. So helping people to become independent and be able to make informed choices on how they can help reduce the symptoms, improve quality of life, and just help manage the condition overall. And then also we can use motivational interviewing techniques to help them process, where they're at on the process of recovery. Are they ready to actually implement change? Are they open to change? Where are they at on it? So you can use MI in helping them through that. And then also developing a biopsychosocial spiritual treatment plan and helping the patients follow through with some of the options that may be discussed in therapy. And then also facilitating family support. As many illnesses and health conditions related to COPD are, sometimes families are impacted from COPD. And so patients may need to rely on other family members for support, for help, for assistance. Sometimes their roles within the families may be adjusted because of limitations associated with the progression of the disease. Many other family dynamics may be changing as somebody progresses in this disease. And medical family therapists can help with many of these options here. As we talk about health behaviors, I wanted to share this quote that I found in the Medical Family Therapy and Integrated Care second edition text. Of the 10 leading causes of death in the United States, at least 7 could be substantially reduced if persons at risk improve just 5 habits: diet, smoking, lack of exercise, alcohol abuse, and use of antihypertensive medications. So I thought that really summed up nicely some of the focused behaviors that we can focus on as medical family therapists in helping people reduce their risks associated with the common leading causes of death in the U.S. So diet, smoking, exercise, reducing alcohol abuse, and also helping patients follow up with antihypertensive medication use. Let's discuss identifying triggers associated with COPD symptoms. And many times these are contributors to the condition, as well as current triggers to symptom experiences there. So let's talk about occupational exposures that are pretty common according to Stephen and Yu 2008. And so dust and gas very much can put somebody at risk of experiencing COPD and exacerbating their symptoms. So some very common mineral dust include coal mining, hard rock mining, tunneling, concrete manufacturing, and silica exposure. And I really found this to be very relevant, especially for many of the patients that we serve through the Chickasaw Nation, because coal mining and concrete manufacturing and hard rock mining are actually very common trades in our area of the state. And so we may encounter patients that have been doing that for their occupation for years and have put themselves at risk of developing COPD, or have COPD now and may be more exacerbated when they're going to work in those environments. Some other organic dusts that could exacerbate the condition are cotton, flax, hemp, and grains. Once again, those are very common occupations in our part of the world. And then some gases that also increase risk too are sulfur dioxide, isocyanates, cadmium, and welding fumes. So if you work with patients that may be exposed to those types of gases, it could make their symptoms worse. And some environmental risk factors that are important to be considered, particularly in the home, exposure to smoke, whether it be direct exposure through personal use or secondary smoke, or even we're finding it more important that third-hand smoke is actually important as well. So that third-hand smoke is actually when patients are not exposed to the smoker, but exposed to people that are exposed to smokers. So for instance, if I had COPD and I were around a coworker who has a spouse who smokes, just by me being near the clothing or the person that brings the pollutants with them, so it could put me at risk. Also, certain types of pets could make it worse. Also, a home that has dampness or moistness in the air, and also infestations can make it worse too, particularly cockroaches. Some of the literature I reviewed, I guess cockroaches, they expel a certain sort of chemical that actually makes is an irritant to our respiratory system. And then when people that use wood stoves or wood fireplaces, that could also put them at risk of having worse symptoms. And also unvented heaters and stoves could also be a risk factor. And of course mold, particularly visible mold, could be a problem with people with this. And also they may live in an environment where they use what's called swamp coolers or humidifiers, can also put them at risk, environmental risk factors too. Some outdoor risk factors include pollens, trees, grass, weeds. So being aware of kind of where we're at on the severity of pollen exposure. Also, extreme temperatures and weather conditions can also make COPD symptoms worse as well. And some chemical risks that could also be risk factors: certain cleaning agents, exposure to certain perfumes, also sulfite sensitivity. So whenever somebody may eat shrimp, dried fruit, consume beer or wine, sometimes they may have a certain sensitivity that makes the respiratory system respond to that and makes the symptoms worse as well. And also beta blocker medications. And so in some of the literature I reviewed, they didn't go into a lot of detail about beta blocker medications and how it may impact COPD. So I went ahead and I went to a pharmacist and asked them, and they said they work on some of the same biochemical pathways. So that's why that they could interfere with COPD symptoms as well. Let's cover some breathing issues associated with COPD. Of course, we talked about shortness of breath or dyspnea, and so we're going to kind of dig into more some interventions on how to help somebody experiencing shortness of breath. I'm also going to kind of talk a little bit about specific breathing techniques, a little more detail, and give you guys some instructions if you want to use pursed lips breathing, and also the diaphragmatic or deep breathing techniques. So let's go into some of those in more detail and talk about those further. Okay, let's talk about the shortness of breath intervention. So when somebody experiences shortness of breath, we can help them learn some activities and behaviors that can help reduce the progression of the symptoms and help them to be able to become more active in the long run. And so when they first start to sense shortness of breath, teach them to stop the activity that's associated with that. And so stop the activity and then rest, so they can sit down or if possible lie down to help rest the body, help the body recover and become homeostatic again. Also learn to relax, and we're going to talk about specific breathing techniques that can help somebody relax. And some of these breathing techniques will literally manipulate certain parts of the physiology to induce relaxation too. And then also cognitive interventions on reassuring yourself. So tell yourself reassuring thoughts about the symptoms. You know, a common way of self-talk that could actually exacerbate it even more would be to feel like I'm suffocating, I'm dying, you know, all these kind of extreme sorts of reactions internally or cognitively, which then will actually increase more anxiety, increase the respiratory rate, and then make it even worse. That cycle we talked about before. Also teach people to be prepared, so take their medications with them. Carry a rescue inhaler if they need to, so that way they can use it immediately when they start to feel some breathing restrictions. And then after breathing improves from all these methods we've talked about, they can gradually resume the activity again. Okay, I'm going to talk about a specific breathing technique now, and medical family therapists can teach patients on how to do this as well. And it's called pursed lip breathing. And what this does specifically, it helps with the ventilation, which is the exchange of gases within the respiratory system. And so it's really particularly good when somebody has that sense of breathlessness. It also helps to release trapped air in the lungs. And so that's a really good focused intervention for people that have those particular conditions. And so here are the instructions for pursed lip breathing, at least introductions and suggestions here. So relax your neck and shoulder muscles. Breathe in slowly through your nose for 2 counts, keeping your mouth closed this whole time. Don't take a deep breath. A normal breath will do just fine. It may help to count to yourself. For instance, inhale 1, 2. Now you pucker or purse your lips as if you're going to whistle or blow out a flame on a candle. And so when you exhale, you put your lips together like you're blowing out a candle or you're whistling. And so then you breathe out slowly and gently through your pursed lips while counting to 4. It may help to count to yourself, such as exhale 1, 2, 3, 4. Now, important point here is, if you notice, inhaling is up to a count of 2, exhaling is to a count of 4. So if you notice, breathing out takes longer than breathing in. So it's kind of an important ratio to consider when you're talking about pursed lip breathing, because patients may have, you know, different lung capacity, so they may be able to breathe in longer than 1 and 2, and so vice versa, they may have to exhale longer than 4. So a good ratio is 1 to 2 from what I've seen with breathing techniques. So that's specifically pursed lip breathing. Now let's talk about a different breathing technique called diaphragmatic breathing, or it's called deep breathing. And this also helps open up space for more air. It also activates parts of the nervous system that helps control relaxation, which also leads to a decreased heart rate, blood pressure, decreased muscle tension, and also relaxation. So one easy way to look at it is if somebody looks at their stomach and they feel like their stomach's a balloon. So they're breathing in such a way that it fills the balloon within their stomach. So they inhale through their nose and their stomach kind of expands as they're filling it with air. Now they're not literally filling their stomach with air, but what you are doing when you're using the technique is actually lowering the diaphragmatic muscles so that there's more space for the lungs to fill up with air. And so using this deep breathing technique frequently helps to bring in more oxygen and expel more carbon dioxide. One useful approach to this is you can actually have patients schedule specific time to practice relaxation techniques and this deep breathing technique. In fact, a lot of, at least my observation has been, a lot of patients will respond to a prescription from a physician, but they may reserve these techniques for only when they're feeling anxious or experiencing problematic symptoms. A good approach is to actually prescribe specific times for them to practice this, and that has a couple of benefits. First off, it teaches them to use these skills when they're not under distress, and so they learn to become second nature to people. They become muscle memory, they become automatic, they become very skilled at using it, and that way when they do need it in a time of distress, it's something that becomes very easy for them to implement. Secondly, it becomes kind of a prevention effort, because as we relax ourselves multiple times throughout a day, what that does is puts us in such a state physically that we become a little bit stronger or more immune, so to speak, to some of these other symptoms associated with the anxiety or other psychosocial issues related to COPD. Now, COPD largely is associated with exposure to smoke, particularly commercial tobacco. And so let's talk about some interventions related to tobacco cessation, because many times patients may be coming to us and they may be using tobacco, or family members may be using tobacco. So tobacco cessation intervention techniques are very important to know when you're working with patients with COPD. And I think it's very interesting to also point out, Hunter, Goody, Ort, and Dobmeyer in 2009 pointed out that nicotine is the most addictive substance. And I'm going to show you a model next that shows how addictive nicotine is when compared to other substances that are very common with patient populations we work with. And also I want to point out that behaviorally our patients need to change habits and also working on the environment to help prevent continuation of that behavior. And then we'll talk about thoughts and emotions that can also be targeted for changing thoughts and beliefs associated with the use of nicotine as well. Here's a graph that shows levels of dependence for different chemicals, their substances, and also levels of physical harm. And this was actually done with a study on primary care providers and their report on what they said were some of the most addictive substances and also the most potentially harmful substances. And so I wanted to kind of point out, if you look at the level of dependency from 0 to 3, you'll find that tobacco is orange and it's up there towards the very top. And you'll see that according to the review from the primary care providers, only cocaine and heroin were more dependent than tobacco or nicotine was. Now I do want to point out this was a survey done with prescribers, and other research has shown that actually nicotine is as addictive as cocaine and heroin. But this graph does visually show us how highly dependent people become on that particular substance. So it's important to be sensitive and understanding about how difficult it is to change that nicotine addiction that people may present when they have COPD, or their family members or close to relations when they may be also using tobacco around the patients as well. Let's just briefly talk about some tobacco cessation intervention techniques that medical family therapists can utilize with patients and their family members. Now, at the Chickasaw Nation, fortunately we have an Office of Prevention Services that has a contract with the state to help with public awareness, public education, to help provide resources for people interested in quitting. And so we have some resources here that we could tap into. So those of you that are in this environment can also utilize those resources as well. So there's some campaigns that some states are into, such as the 1-800-QUIT-NOW, I believe. But you can also do things on your own too in talking with patients. So some techniques include helping our patients to prepare their surroundings. One intervention would be to encourage them not to buy nicotine or tobacco in bulk. So if they are starting to taper off, start buying in smaller amounts. Prepare their surroundings, such as trying to remove options in the long run for slipping back into old habits. Also, they need to be very proactive in choosing a method of quitting. So doing some research and very deliberate in identifying this is the method that is going to be used to help quit tobacco usage. And so some of those techniques include nicotine fading, so starting to reduce amounts of usage over a specific period of time. And that can be part of that very intentional planning for quitting the nicotine. Another intervention is brand switching, so using a brand that tastes or the experience is very different, the quality is very different, so it could be a stronger taste or a different type of taste. That can also help break that connection of that sense of satisfaction or satiation associated with the usage. And then also using aversive tobacco use. And so some behaviorists would say make your last usage something that's very unpleasant. And so using tobacco in such amounts that it actually makes somebody sick or feel bad or something like that. So there's different approaches to use for that. But you can do some more research and find out a little bit more details about those techniques on your own. But I wanted to introduce you guys to the ideas and concepts. And then also the use of the 4 A's in helping our patients to quit tobacco use. And the first A would be to avoid. So avoid environment, situations, exposure that could actually trigger the behavior that they're wanting to quit. Also alter their habits and behaviors. So for instance, if they're in an environment where they're exposed to smoke, they may want to choose to be in a different environment, choose to not go by the same stores that they buy or purchase their tobacco, or in the same environments that they're surrounded by tobacco, and then find alternatives. And so sometimes you'll find people that will start to use hard candy instead of tobacco. And so there's actually some kind of a fake cigarette that people can utilize, and they could suck on whenever they feel that craving to use cigarettes as well. And then also action. What kind of behaviors can be changed related to it? And so you can kind of look in more detail and find out what these 4 A's consist of. But I wanted to share the 4 A's because it seems to be a very simple approach that I think patients can embrace and understand fairly easily. I want to thank you for listening to the presentation on COPD, and I hope that I was able to share some information that may be new or provide a different perspective that maybe you haven't seen or heard before. And so thank you for listening, and I look forward to listening to your presentations as we move forward in the class. And if you guys have any more questions about COPD, by all means feel free to bring those up. There may be something that I read about or that I covered that I didn't adequately discuss in this presentation, so please do feel free to contact me if you need to. Thank you.